we'll get started. They said wait a minute before you get going because it takes people a minute to jump from group to group. My name's Ben Forrest. I'm the CEO of Olio. I had asked, and the group at Health asked us to speak about payer and post-acute partnerships, and so they asked me to formulate this discussion, and I invited a good friend, Lisa Leveque from Ensign, and we'll get into our bios a little bit, but thanks for spending 20 minutes or so with us. And the focus of our conversation today is the word partnership, right? So what does that mean? What's that look like? Payers specifically right now, it's about to be earnings call season, and everybody's going to hear about stocks doing certain things that may or may not be relative to OpEx, cost of care, things of that nature. So we're going to focus on what does that mean to partner with post-acute providers. Lisa, give us, I think everybody thinks of nursing home, right? As this thing where grandma goes when she's sick, but maybe don't realize how big and complex these organizations are. So Lisa, tell us about yourself and a little bit about Ensign to give the group maybe a different idea of what the heck that means.
Awesome. Well, thank you all for, you can hear me okay? Good. So Lisa Leveque, I'm the VP of Strategic Alignment and Care Transformation. I do focus most of my work in Arizona, which is one of 17 states that Ensign has under its umbrella. And we have over 360 facilities across the country, with 344 of those being skilled nursing facilities. We also have another line of business or businesses that include things like transportation, radiology, dialysis services, respiratory services, and much more. And we've really had to get creative with healthcare because in every state that we're in, we don't always have the services we need in order to care for the patient population that's been given to us to care for. And so, as Ben said, we've had to get creative. I'm a little partial to Arizona because that is the state that I primarily serve. But in Arizona, we have facilities that take care of patients that are at the ICU level of care. So they're on a ventilator. They're getting bedside dialysis. We're working with the hospitals closely to care for that population. We also have behavioral health locked units, different levels of behavioral health services. We also have bariatric services. Now you're probably like, oh, well, a lot of buildings have bariatric services. Probably not like we do. We have buildings that care for patients who are over 1,000 pounds that are a younger population, so not your typical grandma, grandpa population. And then we have a mix of patient population. We have a mix of those who live in our skilled nursing facilities because they require that level of care. But they also have that short stay rehab. And we're taking care of patients that are clinically complex, not just those ventilator services and behavioral health services. And then we've also started to venture out. We purchased our first long-term care, acute care hospital in Utah this last year. We also have behavioral health residential facilities that are caring for that substance use recovery population. And then we also just opened our behavioral health inpatient facility caring for a pediatric population with autism with behaviors. So again, we've been able to partner with our health plans and our state Medicaid entities to get creative with healthcare. And I think that's a big part of what we're talking about.
Yeah, and just to give you a little backstory on how Olio comes into this equation is we're hired by payers to create that partnership through software, right? To make sure the right stakeholders are touching each member patient as they're in various levels of care. So what that usually looks like, and these organizations are complex. Lisa mentioned Arizona. That could mean 180 skilled nursing facilities, 50 home health providers, 150 behavioral health residential facilities. How do you create partnership, workflow, continuity, all those things. Software can help a lot with that. We're very passionate about, and I'll ask you a question about this, Lisa, is like, so rarely does health plan care management, health plan utilization management work in concert with the provider in real time, right? So coordinated workflow, dialed in, understanding how to help complex patients. It's something that Olio we're incredibly passionate about. We're thankful that partnership can occur. So Olio is a technical apparatus. We're a part of that partnership, but the partnership really happens with the provider in the post-acute space or behavioral health space and the health plan. And I think the question I probably throw on you, Lisa, is, for a technically driven audience that I presume some of you all are part of, potentially part of the payer landscape, how rare or how often does it happen where a health plan itself has a separate care management infrastructure from utilization management infrastructure, working with the same care teams, not together, but opposite each other, duplicating work on your team's behalf?
Too often.
Give us for those that don't know, we're talking standard operating procedures, authorizations, prior auth. It happens. Patients gets accepted for care. These are Medicare Advantage members, maybe a D-SNP member, not as much commercial, maybe a little managed Medicaid. And the health plan's invested in care management teams, and they're working with Mrs. Smith Social Services or otherwise. And then they've invested in utilization management teams that are working with an entirely different infrastructure within the organization. And they leave what I like to call the third leg of the stool out of the equation. And so that's what we're really passionate about. Talked about how that's impacted and changed how you operationalize the work with the health plan, and then subsequently potentially what the data tells you on the back half.
Well, and to your question, like, we unfortunately do experience a lot of disconnect at the health plan side. During COVID, sorry to mention that word, a lot of staff went to, home-based work, and they weren't coming in our buildings. They weren't engaging with the patients. They weren't engaging with the families and the staff. And a lot of those companies have stuck with that model. We've slowly started to see some come back into the buildings, but that creates a huge disconnect. And then you throw in the lack of connection. And I would say, again, talking about Olio and what it's brought to us across the country with our health plan partnerships has been a game changer. And for us, it's been able to bridge and eliminate really the disconnect that happens even when there's a relationship between a facility case manager and a health plan case manager. And what has happened is now everyone's connected. I can see what's happening on every single patient. The team at the building can see what's happening on every single patient. Everyone at the health plan, including up to the medical director, are seeing what's happening with that individual patient. So if there's a need to escalate, the escalation happens real time. And then you throw in just the ability to have real time performance. And that includes, the length of stay, the readmissions, being able to collaborate on those readmissions so that we can help improve them. Historically, readmissions was a lag measure for us. And through this technology has become a measure that we can actually influence and work together real time to solve.
I'll brag on Lisa's group. How many SNFs do you have in Arizona?
So we have 39 SNFs. We have 10 other healthcare entities, and then we have the 2 behavioral health entities.
So Lisa's group in Arizona is referred to corporately as Bandera, a part of the Ensign Group, and their staff, social services, directors of nursing, building administrators are engaged. I know the percentage. We track engagement. We think that's a key differentiator in figuring out cost of care levers. And her 39 buildings are engaged with Olio's 4 health plan customers in that state over once per patient per day. That's a high level of touch. And she's managed her team not just on cost of care measures, but being intentional about staying engaged with the CM and UM teams from the health plans, utilizing Olio and to ultimately understand how to improve and make change. So kind of stepping forward, how have you seen just the landscape of the payer space? Everything's changing so fast. Obviously, technology's doing what it does. Everybody can look around this beautiful landscape of a conference and see that's happening in real time right in front of us. What's going on in the payer world that you think now more than ever partnerships could be a major driver for the future success? I think we would agree that cost of care might really, it's been talked about, it might be really here.
It is here.
Yeah.
We have had some recent conversations in the last few months, really just focused on that. What does cost control look like? I think the post-acute world has been left out of a lot of those conversations historically, and we can highly influence it. So it excites me to be able to.
Absolutely, you can. I mean, in a big way.
Yeah, for sure. So it excites me to be able to be at the table with our health plans, our hospitals, all of our partners, because we all have an influence to the result of that cost of care. Duplication of services alone is a huge opportunity for us, not duplicating something that happens at the hospital in the post-acute world, and then even worse out in the community. But also just looking at where do we partner better with our health plans to influence through creative, I call it creative care. Like, how do we get creative? And we can't do that without data. We can't do that without sitting at the table and having conversations about all of our partners' pain points. And so that's been huge.
What kind of blew my mind, being with Lisa's team and the rest of the Arizona market for greater than 3 years, is like the cost of care lever for an insurance provider relative to post-acute care is to reduce utilization. Like, that is just traditionally what everybody wants to do. And over 3 years, we've actually seen the skilled market stay relatively flat relative to utilization, but our payer customers saving a tremendous amount of money because they have a true understanding of SNF discharge to home health, assisted living, home care, et cetera. And they're doing a much better job of using that information in real time to impact and coach and work with the SNF provider as that foray into various levels of care. And those levers are what's driving considerable savings for the health plan. And I think there's two parts to that. Like, I think that post-acute care, skilled nursing facilities are always kind of that first line on the expenditure that everybody wants to move and change and execute with. And I would say that's a thing, right? You agree with that?
Yeah.
But also, if you reduce utilization and the same patients come back and you just have 15-day length of stay, but the same patient came 5 times in 1 year, what have you really done, right? So that's what I think. I'm really interested in what's happened in the last 3 years in Arizona, just because we have a lot of size and scale in that state, and we could see how the ball bounces per se. All right, kind of wrapping up here. We're almost done with time, but I think be interesting to hear, and I'll share what I think, but what Ensign is making, you're buying. You mentioned all these different clinical modalities, from behavioral health care to inpatient rehab, skilled nursing, home health, what you name it, assisted living, independent living. Where's Ensign going? What's the future look like? How does that impact the partnership with the payer? Talk on that for a minute.
Well, I think it's something we talk about all the time, is just making sure that we're not getting comfortable. We have to constantly make sure that we are staying ahead of the game and being proactive. And again, this cost control effort on both sides is a big component of that strategy, because it's going to be a shift in the mindset of our individual leaders. And for us, it's just staying creative. It's also getting involved in government relations.
I want to interrupt you. There's probably folks that think that that a post-acute company is going to wants to drive utilization, is not interested in the cost of care. If I heard you right, the future is you being very interested in the cost of care.
Yes. Future is being the best partner we can be to the whole healthcare system, our health plans, our hospitals, our communities being part of the solution. And it's for us, it's there. Like
Yeah.
we've already stepped it up to really have those conversations. But Ben, I would really love to pose that same question to you. Like, what's the future of Olio look like?
Well, I think we're an 8-year-old company, and there's a lot of companies that are finding their way out here amongst us at Health. And I think we found our way about 2 years ago, 6 years into our journey. We know we are really, really good at that kind of community or network provider experience. Like Lisa doesn't have to ask her teams to use our product. They tell her they would prefer to use our product. And that is the cat's meow for the Olio people in the audience. We are going to just continue to do that. We are launching AI technologies to summarize documentation. We're about a month into that deployment of those features to take 65, 70 pages of documentation, prompt it, render it down to one face sheet so that health plan teams can make decisions quicker. Post-acute providers can get the decisions they need quicker. We're going to really invest in behavioral health. We've seen that in the last 2 years with our managed Medicaid book of business. It's a lot worse, if we're being real, relative to payer and provider connectivity. You talk about a residential treatment facility, somebody's doing some really tough rehab work, and we want them to go through treatment and staying connected with health plan CM and UM teams as a provider, providing care for these folks going through severe mental illness or substance use problems is amazingly cool problem to solve. So we are not losing sight of what we're good at, which is important, and excited about the future on that front. So any other things we should talk about, Lisa?
No, I think really just to wrap it up too from our messaging is coming from the post-acute world, but also these other lines of business, just whatever avenue of healthcare you're involved in, from technology to nursing to all these specialty services. I would just say, please include post-acute in those conversations. Please include us as part of the solution because we are ready. We are wanting to have those conversations and be at the table.
Love that. We'll hang out on the side if anybody has any questions or wants to know anything more about us. Again, thank you for taking 20 minutes out of your day. We appreciate you coming. Have a good rest of your show.
Thank you.
Thanks.